bracing. Once they get the abdominal bracing down and they can actually do it, and you'll notice that people can't actually push out fingers. They have no core stabilization whatsoever. Okay? So once he gets that core stabilization down, he does. Okay? Now we can go ahead and look for that pelvic neutral. I'm going to have him keep this contraction just slightly, not a lot. And we're going to go ahead and arch that low back all the way up. Good. And down. All the way down to the ground. Sometimes I'll put their fingers right below their low back so they can feel that they're going all the way to the end range. They can feel the arch of their low back. Okay, this is called pelvic tilting. What is it doing? It's inducing segmental mobility. Remember, that's one of the things I said on the active care progression. So for your exam, it's good to go back to that lecture where it says there's one slide on there that basically you have to own it. It says active care progression. It tells you what the therapeutic benefits for each stage of inflammation is there and what we're trying to do. Inducing segmental mobility for pelvic tilt. We're going to have them do a couple sets. Okay? 3 to 5 times. We could do sets of 10, 12, whatever you'd like to do. It's up to you guys. You guys are doctors. You guys can prescribe. It's not that difficult. I'm not going to give them 20 his first visit, right? I'm going to start off with 10. Let's do 2 sets. How do you feel? If he's okay with that, maybe we'll do a little bit more. If it flares him up, we're going to calm it down. Okay? Any questions about pelvic tilt? Okay. Pelvic rocking. This is something that you guys won't learn here anyway, so I threw it in here. This, remember when I said with low back pain patients, chronic low back pain patients, what happens to multifidus? It atrophies. Okay? It atrophies, absolutely. Okay, MR studies show this. It's proven. So how do we recruit the multifidus? What does it do? Where is its origin insertion? It goes from the DPs above and it goes to the SPs, right? So it does a little bit of rotation extension, right? So we're going to reactivate that multifidus by inducing a little bit of rotation, okay? I want you abdominally brace. This is probably already going to get it to fire anyway by abdominally bracing because it's a functional unit, right? This whole hoop here is a functional unit. We fire some of the core, more than likely the rest of the core stabilizers, like the multifidus, is going to fire as well. So we're already getting it to fire. Now I want us to work a little bit extra. So I'm going to explain to my patient, I'm going to have his hands on his pelvis here. I don't want your pelvis to rock, okay? It's called pelvic rocking, but we don't want the pelvis to really rock, okay? We're going to have his legs about 45 degrees, and I'm going to have him slowly rock his legs back this way without moving his core and to my other hand. Go all the way to my other hand. Okay? Nice and slow. Nice and slow. Perfect. This is re-educating a little bit of rotation in his lower back, right? Where his multifidus is. Nice and slow. Now I want you to go ahead and speed it up just a little bit, see if you can go a little bit faster and still stay in that same control. We're just trying to re-educate that multifidus. Let's just think about it for a second, right? What is this doing? Causing a little bit of, inducing a little bit of rotation. We don't need to do this. We don't need to do this. We need just to fire that muscle just a little bit. You'd be amazed by just doing this and pelvic tilts and bracing how much pain relief they'll get out of just by firing those muscles that have been turned off because their prime movers are now stabilizing the spine. Just by doing those 3 moves that we just did will get your patient doing really well out of pain. Now, if we address any soft tissue mobilization that could be accompanying those prime movers, compensating, we're doing great for our patient. Okay? You guys with me? Yeah.